When it comes to respiratory medicine, interstitial lung disease is the most interesting topic for a postgraduate, and it is equally relevant for your NEET assess. The interstitial lung diseases are a group of diseases which affect the lung parenchyma. There is no standard definition to define it, because certain situations we use histopathological criteria to define a particular entity, and in certain situations the diagnosis is purely clinical or radiological, and because of this amalgamation of histopathological and radiological characteristics, it is difficult to define them as one entity. But to put in simple words, these are the disorders which diffusely affect the lung parenchyma. And as I told you, because we follow complex histopathological and radiological and clinical criteria to diagnose these entities, even the classification of interstitial lung disease is difficult. Okay. The classification that is prevalent right now is what I am showing you on the slide. So we classify the interstitial lung diseases into two major categories: the ones which have a known cause and those ones which we don't know a definitive cause. So the ones which have known cause can be related to exposure, typically occupational exposure. And in the occupational exposure, we know about silicosis, we know about asbestosis, berylliosis, and many more. Interstitial lung diseases can also be drug induced, and this is an important MCQ point. Very frequently we see amiodarone induced interstitial lung disease. Second important drug you must remember is nitrofurantoin. This nitrofurantoin can cause eosinophilic pneumonia, and can also cause interstitial lung disease. The third class, the antimetabolites like methotrexate, this can also cause interstitial lung disease. Among anti-cancer drugs, the important drugs you should remember is busulfan and bleomycin. The list is exhaustive, but these are important from exams perspective and I want you to remember them. Apart from exposure related and drug induced, we also have systemic diseases which can manifest with interstitial lung disease. Classical example is connective tissue disorders like rheumatoid arthritis, SLE, or systemic sclerosis. But apart from this, for majority of interstitial lung diseases, we cannot figure out a cause, and those unknown cause are classified into a set known as idiopathic interstitial pneumonias and other miscellaneous conditions. The miscellaneous conditions, I am listing few important ones. One is lymphangiomyomatosis. Lymphangiomyomatosis is something that we typically see in patients with tuberous sclerosis. This has been asked in PGI recently, so I want you to make a note of it. Okay. The second one I want you to remember is pulmonary alveolar proteinosis and pulmonary Langerhans cell histiocytosis. And the broad classification of idiopathic interstitial pneumonias takes into account the clinical and histological grouping, and under this heading we have numerous entities. To start with, the most commonly encountered type of interstitial lung disease, that is idiopathic interstitial fibrosis, IPF. The second, non-specific interstitial pneumonia or NSIP. Then we can have two smoking related entities, one called desquamative interstitial pneumonia, the second one respiratory bronchiolitis related interstitial lung disease or RBILD. Okay. Then we also have cryptogenic organizing pneumonia or COP. So these are important entities which are grouped under idiopathic interstitial pneumonia. That was about the classification. Now let's look into the demographics or characteristics that help us in making a diagnosis of interstitial lung disease. To start with, age. Okay. Age is a risk factor, and the prevalence of interstitial lung disease increases with aging. Okay. Most of the ILD is present after 50 years of age. The usual age of presentation is between 50 to 70 years. But certain ILDs can present much early. What are those? All connective tissue disorder related ILDs. Then lymphangiomyomatosis. These two conditions can present before the age of 40. Okay. Then sex. Usually males have a significantly higher prevalence of ILDs than females. This has also something to do with the increased prevalence of smoking among males. But those ILDs which are related to connective tissue disorders have a significantly higher prevalence among females, with one exception. What is the exception? The rheumatoid arthritis related ILD is more common in males. Remember, the prevalence of RA is more common in females, but the ILD related to RA is more common in males. So the RA related ILD is an exception. Then, as I told you earlier, drug history is very relevant because certain drugs are known to be associated with ILD, and I will just reiterate the drugs that we mentioned there, starting with methotrexate, amiodarone, bleomycin. Bleomycin was recently asked in names, busulfan, and nitrofurantoin. I did mention that nitrofurantoin is also associated with eosinophilic pneumonias. What is the relevance of family history? Family history, 5 to 20% patients of ILD of any pattern have family history. Okay. And we have recognized a familial form of interstitial lung disease which we call as familial ILD or familial pulmonary fibrosis or FPF. One important point you must know with respect to familial ILD is that the age of presentation is significantly lower, or they present much earlier than their non-familial counterparts. I'll go back to the previous slide and I'll mention that familial ILD may present before the age of 40 years. When we know that there is familial interstitial lung disease, that also means that there is probability of genetic contribution. So what are the genetic contributions? The single nucleotide polymorphism or SNPs on a particular gene which codes for mucin. The gene is known as MUC5B. Actually increases the risk of developing ILD by 6-fold. Okay, 6x increased risk of ILD. And this variant of MUC5B is frequently seen in Caucasians or the whites. Apart from that, we have identified genes which are involved in regulation of telomere length. As you know, the telomere length has something to do with senescence or aging. If the telomeres shorten, the cells senescent faster or age faster, and regulation of that telomere length, the genes that are involved in that process are also implicated in pathogenesis of interstitial lung disease. Which are those? So we have one gene, it's called TERT. The second gene is called TERK. Okay. These two are involved in regulation of telomere length, and certain polymorphic variations are associated with development of interstitial lung disease. Okay. Then third, even the genes that code for the surfactant protein have been implicated in pathogenesis of ILD, and one you should remember is surfactant protein A2. So this gene has also been implicated in pathogenesis of ILD. So three important genes. The first one is single nucleotide polymorphism in MUC5B. The most important point I want you to remember. Okay, and the second one is the genes which are involved in regulation of telomere length, and the third one which regulate the surfactant protein. Smoking history, very relevant. Just like any other pulmonary disorder, even smoking history has been associated with interstitial lung disease. The prevalence of all forms of interstitial lung disease are significantly high among smokers when compared to non-smokers, except one, which is non-specific interstitial pneumonia, which has no history of smoking or typically occurs in non-smokers. But apart from that, two interstitial lung diseases we describe as smoking related interstitial lung diseases. One is desquamative interstitial pneumonia or DIP, and the second one is respiratory bronchiolitis related interstitial lung disease. That doesn't mean the prevalence or incidence of others is significantly low in smokers. We also see high prevalence of interstitial pulmonary fibrosis, Langerhans cell histiocytosis, and even other variants of ILD in smokers. Most of these, by the time they present with interstitial lung disease, have at least 20 back years of smoking history. Coming to pathogenesis, we know very little about pathogenesis, and that's why we call them as idiopathic. Even in those forms of interstitial lung disease where we have a known cause, for example, sarcoidosis or other connective tissue disorder, we know little about its pathogenesis. But from the treatment point of view, we should know the two important points. The point one I want you to understand or remember is that there is a role of fibroblasts, which secrete collagen and are responsible for fibrotic changes. And these fibroblasts are stimulated by transforming growth factor beta and also other growth factors like platelet derived growth factor, then vascular endothelial derived growth factor. These have a positive influence on fibroblasts and stimulate them to produce more collagen and deposit them, making fibrosis. From where these growth factors come? We assume that these growth factors are produced by respiratory epithelium. We don't know what incites the respiratory epithelial injury to produce these growth factors, but we have understood that there is a role of these growth factors, and we have developed certain drugs targeting these growth factors which help in at least slowing the progression of interstitial lung disease. Coming to clinical features, the classical presentation is with two cardinal features. One is dry non-productive cough and second is exertional dyspnea. The productive cough in any patient suspected of or having proven interstitial lung disease should raise a suspicion of superadded infections. Otherwise, there is dry cough, and these patients very often have significant exertional dyspnea, and usual way of presentation is because of the worsening exertional dyspnea. Apart from that, due to pre-existing other medical conditions or associated connective tissue disorders, we may have other clinical features. For example, patients with sarcoidosis may have fever. Patients with systemic sclerosis may have Raynaud's phenomenon. Another very frequently observed finding in these patients is clubbing. Clubbing is very frequently seen. Dry cough, exertional dyspnea and clubbing. All other features are related to other coexisting medical conditions. Once we have known the clinical features, now comes the point where we have to consider diagnosis of interstitial lung disease in a given patient. So, what is the gold standard for diagnosis of interstitial lung disease? It's not PFT, it's not X-ray, it is HRCT thorax. But we do encounter certain variations on X-ray and PFT, and they may be of importance, if not for the diagnosis, at least from the exam's perspective. Starting with the pulmonary function test, the cardinal manifestation of interstitial lung disease on PFT is reduction in total lung capacity. Okay. Along with that, even the FVC, FEV1 are reduced. To some extent, we also notice that there is reduction in ratio of FEV1 by FVC, which is suggestive of obstruction, and this may be more pronounced in those ILDs where obstruction is a common occurrence, such as cryptogenic organizing pneumonia, hypersensitivity, pneumonitis, or respiratory bronchiolitis associated interstitial lung disease. In these conditions, there is a frequent obstruction, and that can manifest with reduction in FEV1 by FVC ratio. Whatever else I just spoke about are suggestive of restrictive pattern. Then most important PFT finding you must know is the diffusion capacity of carbon dioxide. DLCO is significantly reduced as the disease progresses, and serial measurement of DLCO are useful in assessing disease progression. Okay. So this is one finding which helps us to know the disease progression. As the DLCO decreases, we know the disease is getting worse. Coming to chest X-ray, chest X-ray has no diagnostic role in interstitial lung disease, but nonetheless it may have certain findings which may give a clue or help us consider the diagnosis of ILD. Which one? The one important finding is reticular shadows, which are usually bibasal. When I talk about ILD to NEET PG students, I say bibasal, but for NEET SS you should remember posterobasal. Posterobasal reticular shadows may be seen in various variants, typically interstitial pulmonary fibrosis. But that is not adequate for a definitive diagnosis of interstitial lung disease, and hence I say there is no or limited utility of chest X-ray. Do we have a role for fiber optic bronchoscopy? Earlier days, when HRCT was not there, majority of ILDs were diagnosed based on lung biopsy, either open or bronchoscopy guided. But with the advent of HRCT, the role of FOB is limited. But certain indications are there which I will cover. One, serial monitoring of lavage fluid can be of some use, where we are considering DAD, or what I call as diffuse alveolar damage. Helps in diagnosis as well as monitoring. Okay. Second, a ball fluid eosinophilia of more than 25% may be suggestive of eosinophilic pneumonia. Fat globules in ball fluid may be suggestive of lipoid pneumonia. In lipoid pneumonia, we have fat globule laden macrophages. Then transbronchial lung biopsy may be useful, especially when we are considering sarcoidosis. And coming to the gold standard for diagnosis of interstitial lung disease, that is HRCT. In HRCT, I want you to concentrate on two findings. The first finding is what I call as ground glass opacities. And the second finding is honeycombing. honeycombing we typically see in patients with interstitial pulmonary fibrosis or IPF, and it signifies severe lung damage and architectural distortion. On the other hand, these ground glass opacities are nothing but opacities which are not too opaque, in the sense there are opacities which allow us to see through them, and the underlying bronchovascular structures can be seen through them, and these are typically seen in patients with NSIP and various other forms of interstitial lung disease, including COP, RBILD, DIP, or almost every format of interstitial lung disease may have ground glass opacities. But this presence of honeycombing suggests severe fibrosis, and we typically see them in patients with IPF, and in other formats it is less frequently seen. Let us look into some of the ILD variants with some detail, starting with the most important, interstitial pulmonary fibrosis. Remember, this is the most common ILD variant. This is the ILD with the worst prognosis. And I call it as a prototype of ILDs, since almost all histological and radiological findings that we encounter in most other ILD variants can be, not essentially must be, but can be seen in these patients. The reported prevalence of interstitial pulmonary fibrosis ranges from 50 to 200 per lakh population, and since we don't have Indian data, I cannot really make a comment about the prevalence among Indians. The usual age of presentation, just like most other ILDs, is between 50 to 70 years, and rarely ever diagnosed before 50 years, except certain familial variants. The sex distribution, it is predominantly a disease of males. It can be seen in females also, but more common in males in relation to females. Smoking history, almost 3/4 of patients who are diagnosed with IPF have history of smoking. And when it comes to prognosis, the median survival after diagnosis is merely 3.8 years, and 5-year survival is from most reported studies is less than 50%. So that reinforces my assumption that this has the worst possible prognosis among all interstitial lung diseases. Its histopathology, the hallmark of interstitial pulmonary fibrosis is fibroblastic foci. So whenever we have a surgical biopsy sample, we see fibroblastic foci. This is the hallmark of IPF, and these fibroblastic foci demonstrate what I call as temporal and spatial heterogeneity. What do I mean by that? One, these fibroblastic foci are diffusely distributed in whatever zone is affected, and they are at different age of development. All the fibroblastic foci are not at the same age. Okay. Some are in the primitive stage and some have already fibrosed. This varying age of different lesions is what I call as temporal and spatial heterogeneity. These fibroblastic foci typically affect posterobasal, bilateral posterobasal zones. As disease progresses, it may involve other zones, but typical involvement is posterobasal bilateral lungs. Apart from this, because of the architectural distortion and destruction, there will be honeycombing. An important point must remember is that there is little or no inflammatory cell infiltration. This is in contrast to NSIP or non-specific interstitial pneumonia, where we may see significant inflammatory cell infiltration. So these 2 points, the fibroblastic foci with the heterogeneity and little or no inflammatory infiltrates, helps us differentiate it from NSIP on histopathological specimens. The slide that you're seeing on your monitor right now shows few fibroblastic foci here, and also dense fibrosis at different places and honeycombing change. To sum it up, honeycombing fibroblastic foci which are at different age of development are typical of IPF. What do we see radiologically? Radiologically, one, we see reticular shadows or reticular opacities. We can see honeycombing. I keep repeating this honeycombing because this is one thing which helps us diagnose IPF with reasonable confidence when we are considering other differential diagnosis. And third thing we can notice on HRCT is traction bronchiectasis. Because of significant fibrosis which causes kind of architectural distortion, the bronchi are pulled in different directions, leading to traction bronchiectasis. 3 hallmarks. Apart from that, you will obviously notice that the lung volume is shrunken. See, most interstitial lung diseases on imaging, you will notice that the lung volume is significantly reduced. Only few exceptions. I want you to remember sarcoidosis is an exception where lung volume may not be reduced. Then another exception is all those hypersensitivity pneumonias, mainly acute hypersensitivity pneumonias. Again, in chronic hypersensitivity pneumonias, we may have shrunken lung volume, but these two are important from exams perspective. So make a note of them: sarcoidosis and hypersensitivity pneumonitis. You can see on this CT, I first draw your attention to this portion of the lung, which shows emphysematous changes. So since most of these patients have smoking history, there may be coexistence of emphysematous changes, and those who have emphysema, they may not have significantly reduced lung volume. So that is another situation where, apart from sarcoidosis and HP, you may see normal lung volume. But at the bottom of the image, you can see there is honeycombing. So these are all honeycomb changes, typical honeycomb changes. And honeycombing implies significant or severe fibrosis, which is a hallmark of IPF. Another CT thorax, you can again notice significant honeycombing. Because of the poor image resolution, it may be a bit difficult for you to appreciate, but I'll still draw your attention. All these are honeycomb changes. From both these images, you can notice that these changes are predominantly affecting basal lung fields. And as I made an earlier statement, I want you to remember the predominantly affected region is posterior-basal lung zones. Okay. Coming to its management, as I told you, it has one of the worst prognosis of all lung diseases, and only one intervention which has shown significant benefit is lung transplantation. But since most patients cannot find a suitable donor or cannot afford or not fit for lung transplantation, that practically remains not a greater option to treat. So what other options we have? We have an option of using immunosuppressants. Until recent times, until a decade ago, most of the patients were either treated with steroids or cytotoxic drugs. And a standard observation is that these drugs do not improve life expectancy. They neither improve effort tolerance. And there are few studies which say use of cytotoxic drugs is associated with increased mortality when compared to those patients who were not treated, and hence most of us have abandoned using immunosuppressants. But a newer class of drugs, what we call them as antifibrotic drugs, have shown benefit in the form of improvement in the progression-free survival and to some extent reduction in mortality. So there are two class of drugs. First one, perfenidone, and the second one is nintedanib. The perfenidone is a TGF beta antagonist. We briefly discussed the role of TGF beta and other growth factors in fibrogenesis, and this blocks TGF beta. Okay. The second drug is nintedanib. Remember, all these NIBs are basically receptor tyrosine kinase antagonists. This nintedanib specifically acts against, I can't say specifically, but predominantly acts against platelet derived growth factor, and PDGF has a significant role in pathogenesis. So these two drugs have shown that they reduce progression free survival and they also reduce mortality, and hence these are the drugs that we offer to most of our patients when we want to treat. Coming to prognosis, I told you earlier, this is one of those ILDs which has got really bad prognosis. So the 5-year survival is usually less than 50%. The median age of survival is, after diagnosis, is 3.8 years. Coming back to the two drugs we discussed earlier, perfenidone, 0.1, it's a TGF beta antagonist. This is a frequently asked drug, and it reduces progression free survival. It improves the progression free survival, improves mortality, and also to some extent improves effort tolerance or the quality of life. Nintedanib is a receptor tyrosine kinase antagonist. It acts against platelet derived growth factor and vascular endothelial derived growth factor, among others. The predominant site of action is platelet derived growth factor. Similar to perfenidone, this also improves progression free survival, mortality, and quality of life. These are our go-to drugs currently to treat interstitial lung diseases of IPF variety. Second important interstitial lung disease pattern is what we call as non-specific interstitial pneumonia. In contrast to IPF, this has significant better survival or significantly better prognosis, and this is not typically associated with smoking. Most other interstitial lung disease typically occur in those who smoke, but this is not typically associated with smoking. So, who is a typical patient who is likely to get NSIP? These are typically non-smoking young females, usually in their 5th decade of life. So that goes on to say the peak age of presentation is 5th decade. More common in females. Compared to IPF, this has a better prognosis with 5-year survival of more than 80%. On histopathology, we see fibrosis, which is significantly less in compared to IPF, but we also see inflammatory infiltration. In IPF, I told the immunosuppressants such as steroids and cytotoxic drugs are associated with increased mortality because probably there is no role of the inflammation there, but in this set there is significant role of inflammation, and hence these respond reasonably well to steroids. We don't see fibroblastic foci here, we see them in, so we don't see fibroblastic foci here, we see them in IPF. We don't see honeycombing here, or if we see, that is very minimal. On HRCT, again, as I told, we don't see, there is no honeycombing on HRCT and there is no fibroblastic foci. We may see again bibasal reticular shadows. These bibasal reticular shadows appear in almost all formats of interstitial lung disease. The typical finding we see in these patients is ground glass opacities, GGO. The distribution of those ground glass opacities is again bibasal, bilateral and basal. You can see in this CT thorax, these are the ground glass opacities. I told you what is a ground glass opacity. Don't confuse this with honeycombing. In ground glass opacities, we can see through the underlying bronchovascular structures. The resolution of this image is bad. I probably may not be able to clearly demonstrate you, but if you have a CT thorax film in front of you, you can appreciate that you will be able to see through the bronchovascular structures which are underlying those ground glass opacities. Diagnosis, as usual, is based on HRCT. The management, drug of choice for treating these patients is steroids. They respond well, and hence we have more than 80% 5-year survival. Certain patients, if steroids are non-responsive or we want to spare using steroids, we may consider other cytotoxic drugs like cyclophosphamide or mycophenolate mofetil, MFM. For all these drugs, they respond well, and hence the prognosis is generally good. In this slide, you can notice the difference between two entities. See, this UIP, which accounts for almost 80% of patients. UIP is the histopathological term used to describe what we see in patients with IPF. So IPF is a clinical term and UIP is the histopathological term for the same entity. But for NSIP, both on the clinical side, histopathological side and radiological side, we call them as NSIP itself. So both this UIP plus NSIP put together, they account for more than 90% of interstitial lung diseases, and hence differentiating between these two becomes very important. To start with UIP, we see bilateral reticular opacities on both the sides in NSIP also and in UIP also. But the ground glass opacities are not frequently seen in patients with UIP, but they are frequently seen in patients with NSIP. On the other hand, fibrosis and honeycombing are frequent on UIP and they are very rare on NSIP. Forgot to mention that there is significant inflammatory infiltrates on NSIP side, and there are no or minimal inflammatory infiltrates on the UIP side. On the both the sides, because there is fibrosis, you may see significant traction bronchiectasis. Let me take you through a question. Idiopathic interstitial fibrosis is more common in which age group? We have already discussed it plenty of times. So this is more common in 50 to 70 years of age. What ILDs are more common below the age of 40 years? All connective tissue disordered related ILDs like sarcoidosis, then lymphangiomyomatosis and familial pulmonary fibrosis. Few more are there, but these are essential from exams point of view, so I want you to remember. Let me take you through another question. Which among the following histological pattern of ILD has worst prognosis? So UIP, NSIP, COP, RB, ILD. As I told you, the worst prognosis is with interstitial pulmonary fibrosis, which is a clinical term for the histological term UIP. So UIP has the worst prognosis. Smoking related ILDs. A standard note I made that most of the interstitial lung diseases have a smoking history except NSIP, but two entities we typically call them as smoking related interstitial lung diseases. Those include 1. Desquamative interstitial pneumonia, and the second one is respiratory bronchiolitis related interstitial lung disease. Apart from these two, interstitial pulmonary fibrosis and pulmonary Langerhans cell histiocytosis (PLCH), these two have significantly higher prevalence among smokers. So smoking seems to be a significant risk factor for these two entities. Okay. So let us look into these two interstitial lung diseases, which we call them as smoking related ILDs. Both have a similar histological signature or histological hallmark, that is macrophages which are loaded with brown pigment. Brown pigmentary macrophages are the hallmark of these two, and some pathologists call these as smokers macrophages. Both entities, though have a similar histopathological hallmark, the distribution significantly differs. In desquamative interstitial pneumonia, the macrophages invade the air sacs or alveolar sacs, and hence it has more diffuse involvement when compared to respiratory bronchiolitis related interstitial lung disease, in which we see the involvement predominantly affects respiratory bronchioles. So there is peribronchial fibrosis, peribronchiolar fibrosis. And hence the involvement here is patchy. In DIP, the involvement is diffuse and the involvement in RBILD is patchy. Otherwise, they appear to be a very similar entity. And these are one of those interstitial lung diseases which have a very good prognosis. Rarely anybody dies because of the complication of interstitial lung disease in these two sets of patients. Neither DIP nor RBILD has worse prognosis, and they respond excellently. They respond excellently to one, smoking cessation, and second, to steroids. Both of these typically defined respiration related, smoking related ILDs account for actually less than 10% of all interstitial lung diseases. Points to remember about these two: they have a similar histological hallmark or signature, but the distribution varies. It's more diffuse with desquamative interstitial pneumonia, and it is more of peribronchiolar in RBILD. It's easy to remember, D for diffuse, so hence it's more diffuse distribution in desquamative, and R for respiratory bronchiole, and hence it is more peribronchiolar in RBILD type. They have great prognosis, they respond well to steroids, and if you quit smoking, progression significantly halts. As I listed earlier, pulmonary Langerhans cell histiocytosis is a little different entity compared to the Langerhans cell histiocytosis that we see in other organs. Okay. So here, typically it occurs in young smokers. So I mentioned it can occur much before the age of 40 years. Okay. And it is one LCH type which is not associated with bad prognosis, especially if the person quits smoking. Okay. The radiological hallmark of this entity is cystic spaces or cystic dilatation of airway architecture. Okay. Histologically, we see infiltration of Langerhans cells. This infiltration is usually around respiratory bronchioles. And when we subject them to marker analysis, we find one interesting finding, that is, it is negative for CD68. Most commonly employed marker is CD1A. This is an entrance point, a must remember. The Langerhans cells in these patients may be positive for CD207 and S100. The marker CD68 actually is a marker for macrophages and histiocytes too. When we see Langerhans cells histiocytosis in other organs, that may be positive for CD68, and that kind of suggests bad prognosis. But since these patients are negative for it, generally there is good prognosis. Smoking cessation improves the patient's condition, and hence that is one of the important intervention, and steroids are also found to be helpful. The next entity that I am discussing is cryptogenic organizing pneumonia, COP. Very frequently we see this HRCT on our exams and asking for diagnosis. So I will show one or two HRCT images of that. The typical hallmark of this entity is that most of the patients have a pre-existing history of respiratory infection, most likely viral and sometimes bacterial or fungal, or some other inflammatory lung injury, followed by development of cough and dyspnea. Earlier, the same entity was called BOOP, bronchiolitis obliterans organizing pneumonia. But the term is now abandoned, and we address them as cryptogenic organizing pneumonia. Radiologically, we see pleura-based, remember the point, pleura-based often basal, patchy opacities, and an important sign called atoll sign may be seen, which is very sensitive marker for COP on HRCT. Histopathologically, as I told, there is patchy subpleural and peribronchiolar consolidation, and very important MCQ point, we see polyploid plugs of loose organizing connective tissue within the air sacs, alveoli and respiratory bronchioles, and we call these as Mason bodies. So the presence of Mason bodies is histological hallmark of cryptogenic organizing pneumonia. COP again has relatively good prognosis, and they respond well to steroids, cytotoxic drugs like cyclophosphamide and mycophenolate mofetil, and even certain newer biologicals like rituximab. In this CT thorax, you can notice that there is 0.1 pleura based. So the base is lining the pleura. So we have pleura based consolidations. Patchy, this is not diffuse, there is patchy involvement, patchy consolidation. Again, mainly affecting basal lung fields. But if you pay a little close attention to this region, you will notice that there is a central halo and peripheral opacity. There is a central halo and peripheral opacity. Normally, whenever we say halo sign, like as we see in invasive aspergillosis or other fungal infection, there is peripheral dark halo and central opacity. That is a typical halo sign. But here what is happening? There is a crescentic opacity and center is relatively rarefied, and that what we call as reversed halo sign. Another name for this reversed halo sign is, I just told you, atoll sign. This significantly helps in diagnosis of cryptogenic organizing pneumonia. This is relatively specific but not very commonly seen. We see that in only 20% of patients with COP. Okay. But when it is present, it definitely increases the confidence of diagnosis. Then coming to next entity, what we call as acute interstitial pneumonia. This is something that resembles ARDS. Basically, this is ARDS with no known cause. When we say ARDS, we have a typical history of an inciting event, either infection or lung injury. But here, these patients present with ARDS like picture without any inciting event. This is very often fatal. As such, we don't have great prognosis in patients with ARDS. Hence, this is often fatal. The 6-month survival is less than 50%. So, the mortality at 6 months is more than 50%. The point I already made, it resembles ARDS, and the histopathological pattern that we see in these patients is DAD, or diffuse alveolar damage. That is exactly what we see in patients with ARDS too. And since this is an acute event and we don't know the inciting agent, we don't know anything about its pathogenesis. Hence, treatment mainly remains supportive. Most of these patients will land up on ventilatory support, and the outcome is grim. I would like to make a statement here that if you have a question which is asking you about which interstitial lung disease has worst prognosis and there is option of acute interstitial pneumonia, then that should be your answer. This has significantly worse prognosis compared to interstitial pulmonary fibrosis. But if the options listed are only about chronic interstitial lung diseases, then the choice should be interstitial pulmonary fibrosis. Okay. We will do a quick recap. Start with genes involved in interstitial lung disease. First one, very important point, that is a specific single nucleotide polymorphism in a mucin gene known as MUC5B. Okay. So this is seen in 1/3 cases, and this increases the risk of getting ILD by 6-fold. Okay. Then second set of genes, those which regulate telomerase length, TERT, TERK, PARN and ARTEL1, and then those genes which are involved in production of surfactant protein, and an important one which is a proven association is SFPA2, surfactant protein A2. The usual interstitial pneumonia pattern. Okay. See, UIP is a histological or a radiological description of IPF. Okay. But this pattern is not restricted to IPF, but a similar pattern we may see in other entities. As I told you, IPF, then we can see chronic hypersensitivity pneumonitis. Remember, when there is acute hypersensitivity pneumonitis, we see more of NSIP and other patterns, not the UIP. But the UIP pattern we see in patients with chronic hypersensitivity pneumonitis. We see UIP pattern in asbestosis, and we can see them in connective tissue disease related ILD. A point you must remember here is that typical UIP pattern we see in rheumatoid arthritis related interstitial lung disease. Okay. For most other CTD related ILDs usually have NSIP pattern of presentation. Rheumatoid arthritis is an odd man out which presents with UIP pattern. The next quick review slide. Fibroblastic foci we typically see in patients with IPF and asbestosis. Just going back to the previous slide, UIP pattern we see in patients with asbestosis. That's why we are seeing fibroblastic foci. Mason bodies, I just spoke about that. We see them in cryptogenic organizing pneumonia. Schaumann bodies and asteroid bodies, I will discuss them in detail when I cover sarcoidosis, but we see them in patients with sarcoidosis. I'll close the session with a question. Which of the following ILD is associated with worst prognosis? So we have options of AIP, IPF, NSIP and COP. I told you NSIP and COP have good prognosis and they respond well to steroids. The AIP and IPF have worst prognosis. Among them, AIP has the worst immediate prognosis. And hence this should be your answer of choice.